All right, welcome back. Today we are going to move into the second part of chapter 22. In the first part, we looked at bacterial infections of the respiratory tract. Today we're going to look at viral infections of the respiratory tract. As I said last lecture, we're not really going to have time to go into the mycoses. There are a few that are relevant, but based on just time restrictions, I think we're going to leave that. If we get a chance, we can come back and cover that. The format will be pretty similar to what we did for the bacterial infections. We'll look at the infectious agent, the modes of transmission, symptoms, and then briefly we'll look at diagnosis, treatment, and prevention. So first, we're going to start with the common cold, and it's really just a generic term for mild viral infections of the nasal cavity. And as you can see here, there's over 200 viruses that cause the common cold. And right there is the reason why there will likely never be a vaccine for the common cold. There's just too many different viruses that can cause it. But you can see the three most common viruses that cause the common cold are rhinoviruses, coronaviruses, and adenoviruses. And so note here, coronaviruses, right? So at the beginning of this, the emergence of COVID-19, a lot of people, myself included actually, were a little bit dismissive. There have been plenty of coronaviruses. Most of them cause minor disease. Even the outbreaks, MERS and SARS, were nothing like the amount of deaths we've seen from SARS-CoV-2 and COVID-19. And that's part of the reason why, is it was really difficult to predict that there would be such a relatively high mortality for it, and that even if you survived it, that the respiratory distress caused by the virus was going to be so severe. I'll admit readily I was wrong back in March, February and March, and this really has been much more severe than I anticipated, and a lot of people anticipated. So anyway, coronavirus is one of the three major virus groups that cause the common cold. So modes of transmission, nothing new here, right? Direct contact, that's a little bit new, but still droplet transmission via coughing and sneezing. Rhinoviruses can persist on fomites for up to a week. Contact with nasal mucosa or eyes can lead to infection as well. So as usual, you have the coughing and sneezing, the droplet transmission, and as always, the portal of entry often is the mucosal membranes, in this case of the nasal passages and the eyes, I should say. All right, so symptoms, irritation of the mucosa causes an inflammatory response. So the signs and symptoms are a low fever, nasal discharge, nasal excess, nasal secretions, congestion, sore throat, coughing, sneezing, headaches, body aches, may progress to otitis media, as you might remember, infection of the middle ear, pharyngitis or laryngitis, so inflammation of the pharynx and the larynx. So for diagnosis, this is the big one, right? With influenza, a high fever is one of the telling signs. So in this case, the absence of a high fever. We're only talking a low fever, typically right around 100 degrees Fahrenheit. So the absence of the high fever is usually adequate to differentiate from other more severe viral infections like influenza. Typically self-limiting within 1 to 2 weeks with no effective antiviral medications. This is one of the ones you just have to ride out. You're sick for a bit and you get better. So an acute viral infection. So comparison here of the common cold and influenza, right? So high fever here, high fever with influenza, 102 versus 99 for common cold. Headache, they both share aches and pains. That's another one, right? Mild with the common cold, but influenza that tends to be like your muscles and joints hurt very severely. Fatigue, again, slight with the common cold, but severe with influenza. And you typically don't see nasal congestion or sneezing with influenza, whereas you do with the common cold. so let's move on to influenza. The infectious agent is, there are basically three different types of the influenza virus, A, B, and C. They're all part of the family orthomyxovirus, and they have single-stranded RNA as a genome, which tends to be between 3,000 and 50,000 US deaths per year, depending on how virulent the strain is. And so when we get to the next slide, I've got some statistics that we'll cover. It's a disease of the lower respiratory tract, so below the epiglottis, and typically affecting the lungs. The RNA genome is broken into 7 or 8 segments. It varies a little bit based on whether it's A, B, or C. Each segment typically encodes for 1 or 2 specific viral proteins, right? So the capsid proteins, or hemagglutinin, or neuraminidase, right? Each segment of genome will code for 1 or 2 specific proteins. It has a lipid membrane envelope, and the 2 main antigens are the spike proteins, hemagglutinin and neuraminidase. We've seen these before. All right, so let's talk about the 3 different influenza viruses. So we have influenza A. This is the one that typically causes epidemics and pandemics, though influenza B can sometimes be associated with epidemics as well. Influenza C is generally the most mild, rarely connected with epidemics, and it just pops up here and there. All right, so influenza A. There are different subtypes that are based on the structure of hemagglutinin and neuraminidase proteins. So when we talk about H1N1, H1 5N, these are looking at the subtypes of those protein spikes. There are 18 known hemagglutinin subtypes, 11 known neuraminidase subtypes. This is the most virulent of the 3. It can infect numerous animals: humans, pigs, whales, horses, dolphins, birds, and a change to the H or N proteins through shift or drift may be enough to evade host-acquired immune cells and lead to a new epidemic. That's why we tend to see influenza outbreaks every year. It's because they change enough in between each year to infect people again. There's over 200 combinations of hemagglutinin and neuraminidase, but only a few can cause human disease. Influenza B tends to be less virulent, sometimes associated with epidemics. There are no significant animal reservoirs. Changes through drift, right? We saw shift and drift here, but only through drift for influenza B. In influenza C, again, most mild, again, changes through drift, no significant animal reservoirs. So make sure you understand the differences between these 3. Now, normally, do we talk about this in the next slide? Yeah, we do. So I'll leave that for the next slide. All right. Let me take this out of here, by the way. All right. So modes of transmission: direct contact again, or inhalation of aerosols. So remember, the aerosols go more than 3 meters. They're able to float in the air for a bit longer than the droplets, or they survive on a surface. You touch the surface of fomite, and then it can be, or touch somebody that's infected. Those are ways that you can catch the virus. All right, so following inhalation, the virus binds to sialic acid receptors. So we always talk about in tissue, there has to be a specific receptor. So in the case of influenza, it's these sialic acid receptors in the host respiratory epithelial cells. When it attaches to those receptors, it then enters the cells via endocytosis. The cells pull in the virus. So that is through, it doesn't say that here, it should say. So let me add this. So in the host respiratory epithelial cells, it's using hemagglutinin. Right. So when it attaches to these sialic acid receptors, the spike protein hemagglutinin is what attaches to those sialic acid receptors. That's what causes the cell to bring it in through endocytosis. Once the virus undergoes making copies of itself. All those virions, when they're ready to leave, the neuraminidase, so the other spike protein, cleaves that sialic acid receptor. And now the virions can use that to exit the cell. So hemagglutinin in, neuraminidase out. All right, so symptoms, we looked at this in the previous table, right? So fever over 100 degrees. So I guess we should probably say high fever. So chills, severe body aches, followed by signs and symptoms similar to the common cold that may last a week or more. Again, normally self-limiting, but serious cases can lead to pneumonia, right? So if the virus causes infection in the alveoli, or if it causes a secondary bacterial infection in the alveoli, it can lead to pneumonia and other fatal complications. So right here is part of the reason why it's difficult to diagnose exactly how many influenza deaths there are every year, or for coronavirus deaths for that matter, because it's typically due to secondary pneumonia. So it can be very hard to say definitively, all right, the virus caused this. So you'll see a variation in the numbers, the estimates, and it's just part of it, right? How do you know? It's very difficult. They might have influenza. Do you say the influenza killed them, or did they already have pneumonia? Did they already have an underlying health factor? So there's some subjectivity into determining whether the virus was the cause of death or not. So most strains affect the very young and the elderly. That's so in a normal influenza epidemic or pandemic, it's mostly going to affect the very young children and very old adults. However, there's some strains like H1N1 that have strongly affected young adults. The reason being, and I think I've touched on this already, and it talks about it in the book in the outline, is that in the case of H1N1, there was the Spanish flu outbreak in 1918, the immune response was so strong in those young adults that their lungs filled up with fluid and they essentially drowned on that fluid. So in that case, the very strong immune response was detrimental, which was why it affected those young adults more. Normally, the weaker immune response in the young and elderly is what makes it worse. So there are some exceptions to that. But in young and children and teenagers, you can get what's called Ray's syndrome. So the virus causes swelling in the liver and brain. It can lead to neurological damage, coma, and death. It may follow other viral infections, and it can be associated with the use of aspirin. You should not use aspirin for a viral infection in children. Excuse me one moment. Okay, so they have what are called rapid influenza diagnostic tests. They can be used to determine if it's an influenza infection, or you can look for hemagglutination of the red blood cells, or you can look for antibodies for that virus. Treatment, zanamivir, oral oseltamivir, or intravenous perimivir, so 3 antiviral medications. I don't expect you to remember those. So prevention, so we can have a tetravalent or quadrivalent vaccine. And what that means is that it is, in the case of tetravalent, it's vaccinating against 3 strains, or quadrivalent, 4 strains. Right? So you're not just picking one random influenza strain and vaccinating against that. What they do is right now, right, we're in summer, but the southern hemisphere is in their winter. So the CDC, the World Health Organization, other public health organizations, they are monitoring the flu epidemic in the southern hemisphere, and they're paying attention to what the strains are that are currently causing illness down there. Based on that information, they will pick either 3 or 4 of the most prevalent strains, the 2 most prevalent A strains always, and 1 or 2 of the most prevalent B strains. So it really, it's predictive. It's not random, but it's not foolproof either. So what we're looking at is what the other part of the world is doing, and then we'll determine what vaccines to develop. And then once we're in our flu season, the Southern Hemisphere will be watching the same way, and they'll determine what are the likely strains that will cause illness for their winter season. So once they determine the 2 A strains and the 1 or 2 B strains, they'll cultivate in eggs, and they'll produce either an inactivated or live attenuated vaccine, which means they destroy the vaccine, and then use the antigens from that, kill or destroy the virus, and use the antigens of that virus to develop the vaccine, or a live attenuated or weakened vaccine, which means that they damage the virus to the point where it shouldn't cause infection. Now, there's very, very rare cases where it may do so, but typically people say I got sick from the flu virus. They didn't. They didn't get the flu from the flu virus. Now, I'm not saying that never happens, but it's rare. Typically what happens is you take a vaccine, it stimulates an immune response, and maybe you get sick at the same time. Maybe it's because your immune system is tied up preparing a response for what you've been vaccinated against. Most of the time, when people say that they did get influenza from the flu vaccine, I would be hesitant to believe it. Not saying never, but it's rare. Okay, so here's a link. If you'd like to look at this more, I included one of these tables for the most recent influenza season, which if you look down here, so you can look by age group, you can look at how many people were ill, how many visited the doctor or hospital, the doctor, I should say, how many were hospitalized, and how many died from the virus. And notice here it says 95% UI. It's probably really hard to see this, so go to the website here in the link and you can see it a little bit better. And I'm just putting this here as an example. But this 95% is basically a confidence interval. So if you look here, estimate, we'll do 0 to 4 because it's a small number, so it's a little bit easier to understand. So they say they estimate 266 children under the age of 4 in the 2018-2019 influenza season died of influenza. And then you look here, and it actually ranges from 85 to 713. So what they're saying is they think 266 children died, but they have 95% certainty that the real number is between 85 and 713, right? So it's very likely that the real number falls in that range. So when you go down, you can see here all ages, they're estimating 34,157 people died in this flu season, and that could vary from 26,000 to 52,000. All right, so for the 2014 to 2015 influenza season, it was 51,376 deaths. 2015 to 16, 22,705. 16 to 17, 38,230. 17 to 18, 61,099. And then 34,157 for 18 to 19. So you can see we're ranging pretty much between around 22,000 all the way up to 61,000. So give you an idea of what a typical flu season. I don't know exactly what we were at for flu for this year. I don't think the statistics have come out, but I just want you to have an understanding. And really what I want you to take away from this is I want you to get comfortable with looking these numbers up yourself, right? You can just go to the CDC website, and there's a lot of information there. And you can click and you can look through, and you can start to get your own information on this. I want you to be able to look at something like this and be able to interpret it and get a feel for what the numbers are and not be so reliant on what other people are telling you. Now, obviously, you're still reliant on the assumption that this data is accurate. We can have a conversation about why I feel typically the scientific data is fairly reliable if you would like, but This isn't coming from one person or two people. This is coming from a large community that largely regulates itself. So it's very difficult for me to assume that there's some conspiracy behind something like this, because it's not one person or two. It's a lot of people that are checking each other to make sure that the data is correct. All right, so here is our influenza virus, right? So here's your neuraminidase, here's your hemagglutinin, you have your capsid, you have your lipid envelope, right? You have your genetic information and proteins inside the capsid. So going back several chapters, right, and you have 7 or 8 RNA genome sequences that would or segments that would be found inside the capsid. All right, so this just summarizes the 3 major groups of influenza viruses. So A, B, and C, again, severity, whether there's reservoirs, how many segments there are, how they spread, epidemic and pandemic, epidemic sporadic, and then how the antigenic variation occurs. So this is definitely something you would want to know. You're going to see at least a question, if not several, on that. All right, and then here's giving you just some information on historical influenza outbreaks. So the Spanish flu here, 1918 and 1919, which, by the way, all the information seems to indicate that it started in Kansas. So Spanish flu is a bit of a misnomer. They estimate somewhere worldwide 20 million to 40 million deaths. So when people say we've never seen something like this, the COVID-19 outbreak, that's not true. We have certainly seen outbreaks that are as severe or more severe. Maybe personally we have not, but this is only 100 years ago. It's not historically, it's not like the bubonic plague several hundred years ago. There are people alive that were around for this. So 1957 to 58, we had the Asian flu, or H2N2, 1 million to 2 million deaths. 68, 69, the Hong Kong flu, H3N2, 1 million to 3 million, and the swine flu back in 09, 010, which was H1N1, 09, to differentiate between H1N1 in 1918. And that had between 150,000 and 575,000 deaths. So there's a couple links here you would like to, if you'd like to, give you some more information. And just a word on this, right? So often we name a virus based on where it emerges from. So with the more recent, it started off, we were calling COVID-19, I can't even think of it, the Wuhan virus. And people had an issue with that because they felt like it was stigmatizing people from that region. And I understand that, but there is a tradition of naming viruses based on where they were first detected or where they emerged. So not necessarily a bad thing to get away from that. And again, it can be inaccurate as with the Spanish flu. So just giving you a little context on that. All right, next we're going to move into viral pneumonia. So remember, pneumonia is just a generic term for infection of the alveolar sacs in the lungs. So the infectious agent, most common causes, so there are many viruses that can cause viral pneumonia, but the most common are the adenoviruses, the influenza viruses, parainfluenza viruses, and respiratory syncytial viruses, or RSV. As always, the mode of transmission can be direct or inhalation of aerosols via coughing and sneezing. Symptoms, mild cold-like symptoms to severe cases of pneumonia, depending on how strong your immune system is. Occasionally may cause otitis media as well. Diagnosis depends on the agent. RSV causes the formation of what are called syncytia, which are large multinucleated cells from fused host cells. So a bunch of cells, they come together, so they have multiple nuclei, there we go. Which is why they say they're multinucleated. So it forms these big combined cells. In adults, it's typically self-limiting. It lasts 1 to 2 weeks, but for infants, it can be life-threatening. All right, SARS, MERS, and COVID-19 caused by the SARS-CoV-2 virus. I wanted to add more information, but it's still changing so frequently. I didn't really feel like I could put accurate information in here regarding SARS-CoV-2. So I'm just bringing it up generally. It falls in with these other coronaviruses. So they can cause severe acute respiratory syndrome, or SARS, or Middle East respiratory syndrome, or MERS, and coronavirus disease 19, or COVID-19. They're all caused by coronaviruses. They're thought to be zoonotic diseases with hosts like bats, civet cats, camels. Mode of transmission, direct and inhalation of aerosols. Symptoms, high fever, headache, body aches, cough, possible progression in pneumonia. May also be asymptomatic or have mild cold-like symptoms. I don't think, do I have a picture of it? Yep, I do. Oh, no, I don't. So they're called coronaviruses because they have they look like a crown. Let's see if I can add a picture, but that's why they're called coronaviruses. All right, so next we move into measles or rubeola. Infectious agent is the measles virus, or MEV. Mode of transmission, it is very, very contagious. Remember, we talked about R naught. And while influenza and coronavirus tend to be somewhere around 1 or 2, measles is up around 14 to 20, much higher. Very, very contagious. If you come into contact with it, you're something like 95% likely that you are going to have an infection. So again, direct contact with secretions or inhalation of airborne droplets via breathing, coughing, or sneezing. Symptoms, high fever, conjunctivitis, which remember is inflammation of the conjunctiva of the eyes, right? So that redness, the mucosal membrane of the eyes, sore throat. Virus then becomes systemic, right? It spreads to the bloodstream, and then it's going to cause that rash all over the body. It's going to start on the face. It's red, raised, and macular, which go back to that table and look at what macular lesion is. But eventually those spots will come together and be confluent. The rash can last for 7 to 14 days. A very specific sign of measles is what are called complex spots. They're white spots that form on the inner lining of the cheek tissue. It's usually self-limiting. The viral infection is self-limiting, but it can lead to pneumonia, encephalitis, and death. Fatality rate can be as high as 10 to 15%. 2013, 145,000 deaths due to measles, mostly in children. So this idea that I don't need to vaccinate my child with the MMR vaccine because measles is harmless, well, there are at least 150 or 145,000 deaths in 2013. Those families may disagree with you, right? So it can have very severe side effects and can be fatal. It's easy for people to think that it isn't a big deal because really for the last few decades, we had essentially eradicated measles. So we didn't see that. We didn't see that it could be a fatal condition for children. So initial diagnosis is based on this rash and the complex spots. There is no effective treatment. However, there is the MMR vaccine, measles, mumps, rubella. So again, the problem goes back 15 years, I think, to a fraudulent doctor in the UK who published a paper saying that there was a connection between autism and the MMR vaccine. No studies have replicated this. It's been shown that he manipulated his data. He lost his medical license, yet he still travels around. Last year, he was down in Texas, I believe, or Minnesota, still talking to people about this. There's really no evidence, no studies that have shown that there is a connection. All right, so here you can see the rash that's associated with the measles virus. Here you can see the complex spots on the cheek. And here is an electron micrograph of the measles virus. All right, next virus, rubella. So we said the virus is measles, mumps, and rubella. So we move on to rubella, or German measles. So this is caused by the rubella virus. It's an enveloped RNA virus. So it has a lipid envelope, and its genome is made of RNA. It is transmitted by inhalation of aerosols from coughing and sneezing. Symptoms: mild rash similar to that of measles. Close to 50% of those that are infected with rubella are asymptomatic, however, still contagious. They can still pass the virus on to others. The rash begins on the face, spreads to the extremities, however, only 2 to 3 days. Well, remember here, it was 7 to 14. So I'm pointing this out because these be very similar. So it's important that you focus on what differentiates one from the other, right? So in this case, the complex spots, although you might see those, but the rash, 2 to 3 days rather than 7 to 14, that's a big one. Low fever, around 101, and no complex spots. So it may cause congenital rubella syndrome. So remember what congenital means, right? At or before birth. So if a pregnant woman contracts this virus, the virus can cross the placenta, and it can be teratogenic, which means that it causes developmental defects. I guess I should highlight that. Right, so we've talked about mutagenic. Teratogenic means it can cause birth defects. So if a pregnant woman contracts the rubella virus before 11 weeks of pregnant, there's a high instance of stillbirth or spontaneous abortion, still 35%, so a third of the time, if the mother contracts it weeks 13 to 16, after that it drops. But again, this is another one with the MMR vaccine that can be avoided. So people again, oh, it's mild. Why do I care? Well, you care because if you're a reservoir for the virus, you're asymptomatic, and you pass it on to a pregnant woman, you can cause birth defects or abortion. All right, so it's diagnosed based on patient's history, vaccination records, and the appearance of the rash, and again, how long the rash lasts. As with measles, no effective treatment, but it can be prevented using the MMR vaccine. All right, so here you're seeing the German measles rash. So you see it's not as intense, it's not confluent like the measles rash. See how this all eventually comes together. So similar but more mild rash. And here you're showing the virions budding from the cells in a host cell. So these are the virions leaving the cell. All right, next we have the chickenpox and shingles. So caused by the varicella zoster virus, which is a member of the herpes virus family. Now, why does that make sense? Think about that. Why should it not surprise you that chickenpox and herpes are in the same family? Hopefully you jumped to the fact that they behave similarly, right? If you're infected with HSV1, right, you have a cold sore, then it goes away. Right? Then the virus goes latent in the nerves, and it can reactivate later. And what did we talk about with chickenpox and shingles? That it can do the same thing. You can have an acute infection with the chickenpox that resolves, and then the virus goes dormant in the nerve cells, and it can reactivate later in life, causing shingles. So they behave in a very similar fashion. So mode of transmission can be direct or inhalation of material from skin lesions. So it's generally mild and self-limiting in children, can be more serious in adults, may cause birth defects in pregnant women. So it has about a 2-week incubation period. So you're not going to see symptoms until about 2 weeks after you come into contact. Infection of the respiratory tract leads to viremia, which, by the way, so I have a brother that's 3.5 years older than I am, and there's pictures of us as kids, and I can't remember which was which, but one of us, we were standing there looking all miserable on Christmas because we had the chicken pox, and the other one, it was New Year's chicken pox. So so you can pass it around pretty easily. All right, anyway, so around 2-week incubation period, infection of the respiratory tract leads to viremia or virus in the blood, fever and chills as well. And you get a pustular rash, which means it's suppurative, right? It has pus coming from the lesions. It develops on the face, the trunk, and the limbs. The lesions then burst, form a crusty scab. Individuals are contagious from 2 days before the rash until all the lesions are scabbed over. The varicella-zoster virus can become dormant for decades in nerve cells, later reactivated in the form of shingles, which causes lesions on the skin that are very, very painful. And it should make sense. They're on a nerve, right? They travel up a nerve to the skin. So anything that's going to inflame a nerve is likely going to be painful. All right, so diagnosis, that pustular rash on the trunk of the body. It's usually self-limiting. For shingles, you can use a cyclovir, which is an antiviral. I think it's the same one used for herpes. It can shorten the severity and length of the symptoms and reduce the risk of post-herpetic neuralgia, which means that those nerves remain damaged. Even after the shingles disappear, the nerves remain like painful. Like it's just no cause, just like a throbbing, burning pain in the nerves. So there's now a chickenpox vaccine, and there's also a shingles vaccine for people over 60. All right, so here you're seeing the pustular chickenpox rash. And here we're seeing an electron micrograph of human herpes virus 3. Sorry, I'm just looking at this, why they call it human herpes virus 3 here. I would ignore that for now. Go with varicella-zoster virus. All right, so here you're seeing shingles. You can see these lesions that form. This is pretty bad. Typically, from what I've seen, it's maybe one lesion like this. It shows up on the trunk of the body a lot. So I can only imagine how painful that is on the face. And showing a rash here, reactivation of the varicella-zoster virus. So shingles as well. All right, so we have another handy dandy table here that lists the causative agent, the disease, the causative agent, the signs and symptoms, transmission, which is pretty much all contact or respiratory or aerosols, and then the vaccines. So we did talk about the varicella vaccine, the MMR vaccine, the shingles vaccine. So you definitely want to know those. And that wraps up chapter 22. So the information's here on the mycoses. If you want to look, you got coccidioid mycosis or histoplasmosis and blastomycosis. Aspergillus, which we talked about a little bit, pneumocystis pneumonia. So it's all here if you want to look at it, but for exam 4, I won't include any information on the mycoses part. All right, so that wraps it up. I'll have this posted shortly. Then in the next few, probably tomorrow, we'll be moving on to try to have chapter 23 posted and then 24. So I mentioned this last lecture. We've got 22, 23, 24, definitely. 25 and 26, I will look and see how things go. I know it's very congested these last 2 weeks. You've got an exam that starts tomorrow. You've got a lab exam on Monday. You've got exam 4 a week from tomorrow, and then the final the following week. So I'm trying to keep that in mind. So I might shorten up what we cover for exam 4. I'll know more by, let's say, Monday, and we'll discuss it again. So as always, if you have any questions, please reach out. Have a pretty thin turnout at office hours at 2. So if you have questions, let me know. I'm willing to work with schedules so that we can cover things. And I will say this now. If all 40 people in the 2 classes all decide that they want to look at their exams the day before the final, I'm not going to be able to accommodate everybody. Those of you that have sat down and gone through it, it takes probably 20 minutes to a half an hour to go through one test. So It's going to take, even if I speed that up, I'm probably looking at an hour to go through all 4 exams with one person. So I'm not going to have 40 hours of free time to do that. So you need to start thinking about that now. If you haven't reviewed any of the exams, which many of you have not, you might want to at least look at the first 2 exams as soon as you can. Don't try to wait and leave this all to the last minute. I'll do my best, but I likely won't be able to accommodate everybody if everybody waits till the last minute. So giving you fair warning now, start thinking about that and when you'd like to start reviewing the exams. So, all right, I will talk to everybody soon. Thank you.